We also have Rita Siedu saying that there's this rule that CHIPS compound and health centers are not to administer magnesium sulfate. Hence, even when a client gets there, they only administer diazepam and refer. This isn't encouraging. We have another one from Najat Jasmine, who says that yes, but most drugs are not available at the lower levels. They make the policies, but they don't make sure it's implemented properly. All they will tell you is to refer. How do you refer a case without first aid? Since most clients come to these facilities in a stage where you can't just refer, but to provide first aid before referring. We have others also really saying that they are surprised by the statistics that is being provided. We have others also saying early detection is key. That's from Adelaide Charlotte. Then Dr. Linda Van Otu is asking whether maternal death occurring at CHIPS compound. Please keep your questions coming and your comments coming. In due time, they will be read.
Yes. So Benson, thank you for your contribution. Linda, the floor is back to you.
All right, thank you, Joyce. There's a question here from Rita, and I would like Dr. Srofenyo to take it. He's here with us. And it says, I would like to know if it's possible to conceive again after losing first pregnancy to preeclampsia, and how soon can I conceive again to have a safe pregnancy? Rita Ahin would like to know. Dr. Srofenyo, are you here with us? Could you kindly address Rita's question? Thank you very much.
Yes. So the simple answer is that it is possible to conceive again. As to how soon, generally, if let's say the first pregnancy you were delivered by cesarean section, generally we want the spacing between the first and the second pregnancy to not be less than 2 years, and so you can deliver again. However, if you plan that you want to achieve another pregnancy, you have to first speak to your obstetrician and let the obstetrician know how bad the situation was during the first pregnancy, because that is what is going to guide. Secondly, you yourself, you need to be screened. For some of the women, they may end the pregnancy with what we call residual hypertension. So really, the underlying factor for that particular woman may be that she has a chronic hypertension, or she ended up the pregnancy developing a chronic hypertension. And then it is important that that blood pressure you have now is controlled even before you achieve the pregnancy. And all the risks that you have will be, once you're planning of pregnancy, some lab investigations are done to make sure that, yes, currently you are in a state that you can embark on the next pregnancy. So it can be done, but these are not things that should be handled in the lower level. You have to make sure that you have some access to an obstetrician who can guide you, or to an experienced midwife who can guide you from the very beginning through the pregnancy till you get to a point. Thank you.
Yeah.
This is actually part of my presentation. The rest, for those who enter my room, I should be able to share some of the things with you.
Dr. Sroff, before you go, there is this, someone is asking about the role of aspirin and calcium in according to the person, said that the wife experienced preeclampsia and had to undergo cesarean section to save both mother and baby. In subsequent pregnancy, she was put on low dose aspirin and calcium. She wants to know what role and how effective are these drugs in preventing subsequent preeclampsia.
Thank you very much. There is now an emerging evidence. It's interesting. Dr. Linda Van Otu is on the call. There is now an emerging evidence that calcium, for example, in those areas, in those parts of the world where dietary calcium consumptions are low, like our part of the world, West Africa, Ghana, Africa, dietary calcium consumption is relatively low. There is emerging evidence that in those parts of the world, calcium supplementation during pregnancy and starting early enough during the first trimester may affect or reduce the severity of preeclampsia. So there is some evidence there. Again, talking about soluble aspirin, there is also some evidence that for those who have the early onset type, there is some role for calcium. Particularly, there is a particular condition which is associated with preeclampsia, antiphospholipid syndrome. These are not things that our friends should bother themselves about. What is important is for them to tell all their stories to their obstetrician. And then the obstetrician then makes the decision that the risk is such that you need soluble aspirin, or I will just put you on additional calcium, dietary calcium, and so on and so forth. So these two commodities, there are evidences that they can be helpful. But further research is needed.
Thank you very much, Doc. So back to my previous there, are we, let's like, you are also part of the GMA. How are we equipping those at the lower level to be able to manage this so that the mothers will be safe before bringing them to the referral centers?
Okay, so there are national policies in the country on how and the various levels of care that can be given. And we always have to tailor this according to the skill set of the cadre of health workers at a particular level. So if you take, I was following the discussion that people were saying that at the CHIP center, they are not giving magnesium sulfate, but surprisingly, they are giving diazepam. Well, as Stroff mentioned, I'll also be talking about magnesium sulfate, which we think should be readily available everywhere. But remember that magnesium sulfate, if you want to give it at very low levels, studies have been done to look at just giving the loading dose alone, which is not likely to be associated with complications. But to give a full course of magnesium sulfate, the level of monitoring required at a level like the CHIP center might be difficult. But maybe just a loading dose prior to referral, that has been proven helpful in some studies. So in terms of equipping people at the lower level, we have to look at what cadre of staff are there. Are they staff that can enter a vein? Are they staff that can give an intramuscular injection safely? And if they are, then definitely they can give magnesium sulfate, for instance, when the algorithms are met before referring these patients so that they arrive in good shape so that we can continue with care. And I think Dr. Fofie will play a critical role here from the position he occupies and other people in policy so that we can look at our policy and see if we want to adopt that system where you meet a woman of a certain characteristic, clinical characteristic, give the loading dose before you refer. That can be scaled down to the lowest level because at least the intramuscular component of the loading dose can be given safely by most nurses, healthcare, community health nurses who are trained to give injections. But entering the vein and continuing treatment will require some level of expertise to monitor the patient safely. Thank you.
All right, thank you, Dr. Abeyo. So we'll be moving on to the next session. I will encourage all our participants to keep messaging us with your questions and then your contributions. In due time, they will be answered.
Speeding up how we can deal with HDPs. And so basically, the effects of not having the support is many. And as I have already talked about, anxiety, depression, unable to unwind, and then the impact on the family. So in the case of PTSD, for instance, is this going to happen again? I have had this before. Or concerns. They say my BP was spiking. So every time I'm concerned about it, every time I wake up is the first thing I check. When I come to the clinic and the nurses check, it even feels worse. The feelings and the anxiety attached to it. So how can we, as mental health professionals, as users of mental health services, help to incorporate psychological services as part of routine services that we provide to our people? So my colleague Salim will take it over from here.
Yes, to narrow down the hypertensive disorders of pregnancy, go to exacerbate these mental health challenges women and pregnant women will generally go through. So it's important to then put into caveat that pregnant women have some special mental health difficulties they would be dealing with. Now, in lower middle income countries, this becomes worse because yes, also in the document, we notice that in developed world, the likelihood of a woman diagnosed with preeclampsia to survive the pregnancy seems to be higher than in lower developing countries, which Ghana happens to be a middle income or lower developing country. So in that instance, it means that it gets worse, from bad to worse. And then even before the pregnancy, women suffer their own difficulties or distresses with their mental health, from socialized behavior to other things like abuse, to disregard, to some stigma in society. So it simply means that having hypertensive disorder during pregnancy would not only increase your mental health difficulties as a woman, but can be very dire or severe if not assessed, diagnosed, and treated.
Apologies, I think Salim's internet connectivity is a bit poor. Just give us a second. Hopefully he can reconnect. Whilst we wait, if you have any questions, any experiences to share, please feel free to type them in the chat box, or you can also raise your hand and share.
Okay, so as I mentioned earlier, my colleague Salim will be joining us. But as we talked about, let's have these pictures in mind. One person, so the saying about one feminist who said that a woman's body is not hers as much as a man's body is his. So take the woman without an HDP. We're building a mental health model here. Imagine having to deal with a sense of worthlessness, a sense of hopelessness, which is in this case more likely depression. And sometimes it will manifest in the form of anxiety, overly worried about the pregnancy, like Dr. Fofie said. It comes to a point where you're torn between mother and child's health. Another example is in Koiwah's instance, where she says, I have seen this, my mother may have experienced it, but it was not told to me. So these are things that the women have to deal with. By saying women, I put myself in there. Or even if you're not a woman, you know somebody who's been pregnant. And even if you know somebody, you have also come into the world as a product of pregnancy. So we're picturing this, and then we are moving on from this point. And these statistics are growing, and more so when it has severe implications for mortality. Again, why is it important to establish psychological support from the very early stages? Right, okay, I think Salim is here again.
Yes, I'm here. Thank you very much for stepping in, and please stay on alert if my internet fails me again. So we're talking about how then there's trauma during this period. So pregnancy, as predicted earlier, is supposed to be a moment of happiness for the family, for the mother, and for the significant other. However, if there's preeclampsia, yes. So like I was saying, hypertensive disorders in pregnancy would make mental health dire or severe. And the younger the age of the mother, the severe nature of the preeclampsia, the lower gestational period, as well as the admission period, can all lead to some traumatic episode for this mother or this woman who's experiencing preeclampsia. And the most unfortunate scenario is when the mother would have to lose their baby because of immaturity or lack of some facilities to help her deliver safely. Now, this puts her in very, very traumatic situations. And for most women, it's easier to not pay attention to these traumas and move on, because dealing with negative emotions can be difficult. However, trauma is something that you cannot avoid. No matter how hard you try to suppress it in the unconscious, they will find a way of getting at you. And that's why the statistics says that most women who go through traumatic episodes will have a postpartum depression or some post-traumatic stress disorder after delivery. And some of the symptoms we have to look out for in mothers who have had preeclampsia during pregnancy and after delivery is the intrusion of thoughts. For most people, they will report having thoughts about how the experience was, the pain they went through, the admission period, the cesarean section, the medication, the sleepless nights, and they try to avoid these thoughts. So they don't want to give it much attention. And this can lead to a lot of hyperarousal, sudden mood changes, some anger outbursts. Some mothers also do report sleep difficulties pre-delivery, during the pregnancy, and sometimes post. And there's a lot of anhedonia, which here means that loss of interest. So after a mother has delivered, we find that sometimes she loses interest in most of the things when it comes to work, when it comes to socialization and other things. And then sometimes there's non-adherence. And you hear the health professional complaining that I put you on this medication, you had a review last week, you missed it. This is because this mother or this woman is going through some mental health distress, which takes power away from her to make some decisions, but needs help or support. So how do we help mothers in this scenario, or how do we help women who are going through this distress? I have put my interventions in different levels, because for most of the time when we talk about psychotherapeutic help or mental health support for mothers, we then see the clinical psychologist as the only resource, or then we are thinking, how do I get this support? In our parts of the country, these services are not easily available. And sometimes a mother may not have these things at her disposal to get support. Even earlier in the presentation, we're talking about the various levels of healthcare, from the national to the regional to the district. You get to some districts, and yes, there wouldn't be a clinical psychologist at the facility to attend to the mental health needs of this mother. What can we do? So we'll start with the personal abilities or the personal interventions that, as a pregnant woman or as a significant other, as a family member, you can draw the attention of this pregnant woman to, or can aid her or to go through a safe pregnancy whilst taking care of her mental health. And the first one will be to maintain a routine. Sometimes we tend to want to think that things will happen by default, and that I'll wake up in the morning and I'll be fine, and I'll go for a review and my blood pressure will be fine. But you need to maintain a routine that ensures your well-being. And this maintaining of routine includes your sleep pattern, your appetite, the work you have to do, who you have to go to, and when your review is due. Do not leave your well-being to chance, especially during pregnancy. Have a routine when it comes to your work. If you have to take some time off work, please do. With your social responsibilities, if you have other children, the tendency to want to multitask, take care of the younger ones whilst dealing with your pregnancy, and even sometimes taking care of your spouse or partner. You need to have a routine that doesn't stress you. If you are in school, sometimes you have to ask for times off or ask for extension to be able to do work in times that are healthy or times that are adaptive to your well-being. And then exercise and healthy eating patterns. Yes, during pregnancy, there's cravings, irrespective of what diagnosis the doctor gives. There are cravings for women, and the tendency to want to eat anything or everything that comes your way is there. But it's the need to also engage in healthy eating habits, things that will facilitate your well-being, things that will facilitate the fetus's well-being, and it's very important. And then engage in some form of exercise as a pregnant woman or as a significant other. Remind your partner to engage in some form of exercise to keep her active. Communicate difficulties. There is the tendency to also want to keep everything to yourself, or it could be that the moment you try to speak about it, you were judged, you were stigmatized, you were stereotyped. So you don't even want to open up and talk about your difficulties, either to your partner or to your work colleagues or to your family. But it is important to communicate difficulties, first of all, to your health professional. When you go for your review and you are feeling lonely, you are feeling sad, it's important to let them know, this is how I am feeling. When the sleep patterns change, please inform your practitioner. And when you are home and you can't do a thing, please communicate. Ask for help. Tendency for us also to want to feel like superwomen and supermen does exist. So I have seen cases where pregnant women will want to do everything and would not ask for any help. Even when the diagnosis is that severe, they still would not ask for help and will be moving around all alone. This can be dangerous, first of all, to your physical health and can be traumatic for your mental health. So please ask for help, be it medically, socially, occupationally, and do that. And then socialize. Earlier, I had mentioned that some of the symptoms of trauma might be anhedonia, loss of interest, or some withdrawal by the pregnant woman. It is important to have a social support group where you can communicate your difficulties and pick up some positive behaviors that allows you your well-being or allows you to vent to other people, so you don't have to suppress all the trauma and the pain you go through during a diagnosis of preeclampsia or during your pregnancy period. Now, beyond the personal, which I mentioned, which the pregnant woman can do, socially, we all have a responsibility. Being a brother, being a sister, being a spouse, being a mother, being a father, being a colleague, whoever you are, there's a need for you to provide this listening ear for whoever it is that is going through this challenge of having to deal with a pregnancy and then a diagnosis of hypertensive disorder of pregnancy. Like I said earlier, it exacerbates their situation. So be there to listen to their worries, to their complaints. Do not write it off. Do not say they are being all mushy or they are being all lazy. You have to listen to their complaints. Avoid judgment and stigma. I know it is easier for you to blame another person for a difficulty. Negative emotions are sometimes difficult to deal with. So it's either to just say, oh, she's being lazy, she's just being too emotional. Avoid these judgments and then listen to them, like I said in the first one. Engage in social activities. Yes, pregnant women can have their mood episodes, mood swings, or not wanting to engage. But you as a partner, you as a friend, can set up some activities that allows them the opportunity and the choice to join at times when they can. This allows them to vent, it allows them to pick up some positive skills, and allows them not to really feel sad all alone in their corner. And now join in. I know gestation is for the woman. Yes, she carries the baby throughout and the delivery, but be a part of the gestational journey. How do you do this? Escort to the antenatal clinics, listen to them when they want, sit with them and ask how the baby is kicking, ask for their emotional, their thoughts, and their behavioral changes that are happening. Be a part, make them feel like you care as a brother, as a father, as a sister, as a mother. And the most important one within the society is to observe. Observe for changes in the pregnant woman. Like it was mentioned earlier, hypertensive disorders of pregnancy have some physical symptoms. And if you do observe, you can also see and then prompt them. This could be one, changes in their physiological appearance. If there's any swelling on their feet, if there's any swelling on their faces, if they are being slow, if they are being withdrawn, observe these changes and draw their minds to it. This would help allow them to seek for help when they go for review or open up to you as to the difficulty they might be going through. Now, let's move from the social, which all of us can play a role, to the professional. Yes, mental health can be as basic as feeling sad, but it can be severe as having a depressive disorder. And sometimes people tend to mistake sadness for being depressed. Having a depressive disorder or having a depression is a disorder that needs to be diagnosed with some specific symptoms and cannot just be brushed off by changing mood. So when you notice that this pregnant woman who has been diagnosed with this hypertensive disorder, you've provided the social support, you've given the listening ear, you have supported in ways in which you can, but she's still engaging in the crying spells, she's not eating well, sleep patterns have been disrupted. It will be important to draw the attention of the general practitioner to refer this pregnant woman to a professional who will help her deal with her thoughts, her emotions, and her behavior. And this is not just a one-off thing, but she would have to go through a psychological screening. So here at the hospital, what we sometimes do is at the antenatal clinic, we have screenings for depressions, anxiety, trauma for mothers who are reporting at the antenatal care. So once you score a significant score, that indicates that there are symptoms of depression or anxiety, then you quickly have to see the clinical psychologist for a session. And it's important that as a professional, insight and psychoeducation is given. Insight is simply letting the pregnant woman know what she's going through, understand how her situation can affect her emotions as well as her thoughts and her behavior. And psychoeducation simply also, just like insight, is drawing her mind to the fact that despite these challenges being there, you have ways or things you can do to replace them, because thoughts are not static, behaviors are not static, and moods are not static. They do change, but they will not change on their own unless there is some change or something that causes them to change. And there's a need to sometimes put psychotherapy as part of the antenatal or the gestational journey. I know you do not have to wait till you have severe preeclampsia or diagnosed with preeclampsia. Even during prenatal care, it is important for pregnant women or women planning to get pregnant to have some psychotherapy. This is to be able to detect some maladaptive behavior patterns they may have that would not ensure their well-being during pregnancy or can cause them difficulty, and then signposting. So whilst you are doing assessment for a pregnant woman for her physiological and mental health, have some referrals to the dietitian, to the physiotherapist, to help them deal with the various issues that would come up. So it's then supposed to be a holistic healthcare delivery for this woman. Then there is the cognitive and behavioral support. This would mostly happen when there are anxieties, there are depression that have been diagnosed in these pregnant women. So we might have anxiety secondary to gestational hypertension. And to be able to deal with this anxiety or depression, we start from the thoughts of these pregnant women. Because when you go through trauma, there's a tendency to magnify the pain and the difficulty you are going through, and then minimize your ability to get better. So you then develop some irrational thoughts about yourself. It leads to low self-esteem, loss of confidence, feelings of hopelessness, feelings of worthlessness, which needs to be replaced cognitively. And when that is done, some behavioral support in terms of having a hobby, engaging in some tasks, taking some walks, and doing some breathing exercises can help a pregnant woman to come out of these distress. And finally, disclosure and grief therapy, which is one of the very important or one of the difficult aspects of dealing with women with preeclampsia during pregnancy, because just like was said earlier, there's a likelihood that either the baby or the fetus will not survive, or both fetus and mother might not survive, or any of these things may occur. When it occurs, what do you do? I have had instances where mothers who have lost their fetuses or pregnancies stayed in the hospital for up to 3 days and were still not told what had happened, because both the consulting doctor, the nurses in charge, and everyone around did not know how to disclose this bad news to this mother. And sometimes it's understandable, because negative emotions are difficult to deal with, be it a professional or not. And therefore, that moment of breakdown, that grief period, that wailing, how do I deal with it? It is okay and it's normal for a mother who is going through difficulty or hypertensive disorder to cry. Do allow her to cry, do allow her to vent. Venting is one of the most important parts of well-being. So if a patient or a sibling or a partner is going through distress as a result of pregnancy and has been diagnosed with preeclampsia or has lost their baby, please give them some space to vent, to cry, to talk, to wail. Do not ask them to move on. Do not ask them that it's okay. And grief has no timeline. Grief has no set out model, or we don't say that your sister grieved in this way, so you should also grieve in this way. Allow people to express their grief in ways that are comfortable, in ways that makes them to heal easily. Now, all these interventions we've been talking about, personal, social, and non-professional, would not come to fruition when the institutions, that's the hospitals or the referring clinics that these mothers go to, do not ensure some basic things. One is the protocol of care that should be ensured. For most facilities, yes, there might be the protocol that when a woman comes for antenatal clinic, there's supposed to be an assessment of her mental state, there's supposed to be a screening of her depressive tendencies, anxiety, trauma, or sugar levels. The tendency to want to ignore these protocols because you assume she's fine is there. So let's try as healthcare professionals, as people in our institutions, to follow the protocol of care for pregnant women, especially those diagnosed with preeclampsia. And then availability and affordability of service. Like I said earlier, yes, the services of a clinical psychologist might not be that affordable or available in your community, but there are very personal things you can do to ensure your mental health even before it becomes severe. And when it becomes severe, it is important that we do a community-based service so that district clinics, district hospitals will have psychologists, if not on call, referred or available to see patients on regular basis so that they do not have to suppress or accumulate their trauma till it becomes psychotic. And then regular updates and review of protocols. The tendency to want to stick to what is old, what we are used to, how conservative we can be, so that it is said that, well, our mothers used to go through pregnancy and they didn't complain. So don't come complaining about any emotional difficulty or some trauma or some anxiety. It is very important that we update, collect data, and know the stages in which mothers who are pregnant or women who have been diagnosed with some difficulties during pregnancy are going through.
We are enjoying this discussion, but Dr. Salim, I'll then treat you to please round up.
Yes, I'm almost there. So research and policy in providing healthcare or providing psychotherapy and help to pregnant women, there are very key things that we cannot ignore. First of all, as healthcare professionals, as mothers or women who get pregnant, as people who support them, data collection and analysis of patients' challenges. Patients always come into the hospital and give you their difficulties, their challenges. What do you use them for? Does it give you any insight into what you should do? So it's important to keep this data and then analyze them to improve on care each and every day. And then periodic review of policies to update care strategies, like I mentioned earlier. Expansion of care to all persons. Community-based care is the way forward. Because we might not have enough facilities, there's a need to even begin to train people within the community to identify mental health difficulties among pregnant women and then provide support from them in their small way. And then implementation of existing policies of well-being. Yes, it's very, very rampant in Ghana that there might be laws or policies that guide a thing, but no one cares and no one implements them. So it's important for us to draw our minds to the fact that the pregnant woman goes through episodes of trauma, goes through episodes of depression or anxiety, and we should make policies to also take care of that. I'll conclude by saying that it's come to stay, and it's very, very understandable that healthcare is biopsychosocial, and it's the same for the pregnant woman. Whilst you are taking care of the physical symptoms of protein in the urine, increased blood pressure, please pay attention to the mental state of these mothers. Check for depressive episodes, check for sleep patterns, check for appetite, because these things will go a long way to influence the quality of care and the outcome of the pregnancy, because it influences the adherence as well as the exercise and the eating habits. And shared decision making, this is very critical. Yes, in healthcare, the tendency of the professional to want to impose or suggest ways by which a patient will do well is advisable. However, get inputs from the patients as well and all other persons who are involved in the well-being of the pregnant woman, especially one who has been diagnosed with preeclampsia. You don't diagnose the case and then not ask how she feels about it or what she thinks about it and what she wants to do about it. Inclusive care. Here, I want to talk to the men who are on the call or on the conference or in this room. It's important that when a partner is pregnant, you are part of the gestational journey. because you need someone to vent to, someone to support. And yes, you can also be traumatized by the difficulties and the challenges she will go through. So also talk to someone if you need to. And community education and advocacy is something we must all engage in, which is one of the things we are doing here. So when you leave this room and you go back to your spaces, ask yourself, what does the pregnant woman in my home, in my community need? Is she okay? Is she sleeping well? Is she depressed? Or can I be of help to ensure her mental well-being?
Thank you very much for that presentation, Salim and Beatrice. That was great. We would be happy to take some questions in the chat. We have 3 more minutes before everyone will return. If anyone has any questions.
Thank you very much, Salim and Beatrice, for that insightful presentation. Indeed, don't leave your well-being to chance. There are levels of intervention that a pregnant woman has to attain: personal intervention, the social, the professional, and the institutional intervention. These are all available to women who experience depression and anxiety. Thank you for sharing so much insight with us. There was a question in the chat box that I saw and I would like to share with you. And it had to do with the association of mental disorders with witchcraft. I wanted you to pick your minds on that. If Dr. Salim could share his thoughts on that. A lot of times in the African context, and of course in Ghana, we associate mental illness to witchcraft and all that. How do you handle this in clinical practice? And how do you advise women to approach this? Thank you.
Thank you very much, Dr. Fonjo. So mental health is influenced extensively by culture. So depending on the cultural background of a place, the diagnosis, assessment, and treatment of mental health is affected by the cultural practice. And yes, in our part of the world, problems that are beyond objective analysis, that we cannot make sense of, or that we do not understand, we want to give it to a supernatural cause. So it's not only for mental illness, but there are a number of things that occur in our daily lives. If we cannot make sense of it or we do not understand it, we quickly want to find a supernatural reason or a cause to assign it, because then it makes it easy for us to not take responsibility. And it's one of the things I was saying earlier, that the taking up negative emotion like sadness, anger is difficult. So you want to blame someone quickly for it. And yes, mental health has been stigmatized because when psychosis happens, which is usually characterized by hearing of voices, seeing of things that the one close to you cannot see, it's easy to just say, okay, then there's some God or some curse that is happening to, or that this person may have done something against, who have cursed or have possessed this woman. However, professionally, the human brain has 3 parts. Let's talk about the unconscious mind, the semi-conscious, and the conscious. Your unconscious mind can take control of your consciousness and therefore begin to give you information that you have suppressed and you are not aware of. Just like it happens in your dream or when you are under the influence of alcohol, where you say things or let things out that you were not really conscious of. So yes, mental illness includes psychosis, and not all psychotic episodes are influenced by spirits. But yes, we have come across people like that who would say that it's a spiritual cause. But when they go through either psychopharmacology or psychotherapy and they get better, we redo the assessment and then we ask, are the spirits still around? I think I've had a patient who came in and was saying that, look, this thing, it's in my family. My mother had it, now I'm having it. Because you know that sometimes mental illness has genetic or family traits or history. So if it exists in the family, the tendency for it to occur does. And she came in and she was saying that, look, we can't do much about it, but we asked her to give us the opportunity to take care of her. We put her on some medication, and after 6 sessions, she came back and said, I don't hear those voices again. I sleep very well at night, and now I'm able to work throughout the day without having the episodes. So it means that mental illness can be without a spiritual cause, but I am also well aware that the culture of a people does play a role. So we engage in the eclectic approach. Bring your spiritual or add the professional. Your well-being is paramount. That's the most important thing. Thank you.
Thank you very much. Probably one last question. You did emphasize that we should incorporate psychological support into clinical practice. I'm not sure how fast that is catching up with us here in Ghana. And you emphasize that that should, in fact, be incorporated into the prenatal care. What steps do you think we can take to achieve that? Dr. Beatrice, if you can share your thoughts on this.
Okay, so thank you. So support is not just, shouldn't just be restricted to clinical support. For instance, calling, actually going to see the person, spending time, sometimes even sitting in silence, and sometimes giving money. So it could be social, it could be tangible, and it could be intangible. So when we are looking at support, there are some questions that we can start with. Empathy. If I was in this place, what do I want to hear? And sometimes you ask yourself this question, and if you answer it well, and without putting too much of, oh, this is how it should be, but rather, what do I want to hear if I was in a place like this? If I was dealing with depression at whatever stage in my maternal journey. And another way, again, is sometimes moving the support from just the restricted clinical times. Sometimes texting people back and forth is a form of support. And sometimes even really, like the question you asked about witchcraft. So if they are witches, what can you use to combat them? So sometimes music, sometimes self-help groups, getting a chance to talk about your concerns and your symptoms in an environment that is endearing, an environment that is non-judgmental, that does not elicit blame or guilt. These are all forms of support. And even in the clinic, the way we communicate, sometimes it is not just in the message we give, but it is in how we give it. So people will come to hospital, and if you follow them up, they would say things like, I'm surprised the whole hospital has called me. For them, that is a kind of support. So support generally is anything that we are doing to ease the burden. It shouldn't be the grand systematic setup, but it's the very, very, very little things that we can do one to another, because we have a duty of humanity in terms of how we relate, especially so when we are dealing with a vulnerable group such as pregnant women or women in various stages of their maternal journey. Thank you.
Thank you, Beatrice. There's another question here that says, what is the best approach to promote adherence in psychotropics? Any of you can take that, please.
Okay, so we're currently we've currently rolled out a study in my department of psychiatry, where we noticed that adherence was failing. And so we did a multidisciplinary approach. First of all, had times picked out those who were struggling significantly with adherence, and then tried to find out why. You'd be amazed that issues such as poverty came up, that even sometimes coming and following up, how to get the monies to come. And sometimes most of our antipsychotic or psychotropic medication demand that you eat quite a lot. So if you don't have the money to even transport yourself for continued care, then what are the chances that you can feed as well as the medication demands? Some of them to require that you sleep quite a bit. So the adherence, there may be general approaches to it, which is talking to your clinician to look for other variants of the medication that may not have the same effects that put you off following the medication through in the first place. So these are, if you feel that I can't afford to deal with the side effects, I sleep a lot, I noticed I'm gaining weight, I noticed that, well, my breasts are feeling a bit heavy, I'm unable to carry myself. Talk about these symptoms, because we want to come to the point, like Salim mentioned, using the community approach where we normalize talking about some of these things, because it is the lack of information sometimes that affects the rate of adherence. So information is available, and then help. So talk about your concerns, be willing to mention it. The era of coming to hospital and every question, I'm fine, how are you, I'm fine. And then we as health service providers remind them that you're paying for this service. Perhaps you want to tell me more than I'm just fine. I don't think you came all the way from home to tell me you're fine. Let's break the ice. Let's make it easy for them to communicate so that the rate of adherence is good, is appreciable, because at the end of the day, they stand to benefit more. So it's significant to look for the reason for not adhering. That is the way to start. Thank you
very much. We'll take our last question, and it's from Emanuela, and she says, I would like to know your thoughts on having women who lose their babies on the same ward as mothers with live babies. Salim, would you want to share your thoughts on that, please?
Yes, it takes me back to what we call availability. So I think it's one of the things we've had to fight with matrons and in charges with, because for most facilities, they say they don't have enough beds. So if there are 4 people in a room, then one mother loses the child. Now move that mother to a place where she can grieve appropriately. Then the complaint is we don't have any extra room. All our beds are occupied. So she has to stay in that room to go through the trauma of listening to other babies cry, to see other mothers breastfeed their children till she's discharged. And yes, it's not the best of situations. If it is possible to put mothers who have lost their babies in separate rooms, it's the best thing to do, because then they don't have to relive their trauma. I had cases where you get into the room and the only complaint the mother has is that I can hear the other babies cry. And this only trigger me and make me feel sad. And I wish I could get. Fortunately, most facilities with age, what we usually do is that we've had to work with the ONG as well as the HDU to have one room always available for mothers who have lost their babies, so that if there's another mother there, you just replace, or if they can pay for VIP service, they go into just single rooms.
Thank you very much to you both. It's been insightful, very educative listening to the two of you are clinical psychologists in the house. It's been very educative, in fact, for me, and I'm sure for all our participants. And so we want to thank you very much for taking time to share such rich knowledge with us. We are ready to reconvene, and so we'll wait for the other members and participants who have joined the other group to join the main group, and we can continue with the conference. In the meantime, we'll entreat you all to keep your questions coming. We are sure our team of experts are still around and they would engage you in the chat box as well. Thank you all. At this point, we wait for everybody else to join the main group. Welcome everyone to this next segment. As already been introduced, Dr. Raphael Arku will be speaking on prescribing cleaner air and quieter living environment as catalyst for improving the outcome of hypertensive pregnancy, hypertensive disorders of pregnancy. A brief profile about Dr. Arku. He's an assistant professor, Department of Environmental Health Sciences, University of Massachusetts in the US. His research and teaching is primarily in air pollution and health, with strong interest in global pollution and health. Specifically, his work focuses on how features of the living environment, household, energy use, and poverty influences environment in air pollution-related health outcomes in data and resource-poor settings. He synergistically combines primary field work and modeling. He's currently working on both local and international lines of research. On the international level, his work addresses important questions in global health on how socioeconomic factors, household energy, and high levels of air pollution in cities disproportionately influence this pollution in healthcare in lower and middle income countries. Ladies and gentlemen, please welcome Dr. Raphael Arku. Doctor, the floor is yours, please.
Thank you, Linda, and thank you, organizers, for having me. I hope I'm loud and clear. Okay, thank you. So I'm on a road. I'm in another program, so I'm in an awkward situation. So I'll keep my camera off a little bit and just make sure we focus on the talk itself. So having listened so far, I think this talk is a little bit not completely in sync with the key discussions so far, but I think it also at the same time will be interesting to look at things from a different perspective a little bit. So I'd like to say that the goal of this talk will be to throw a little bit more light on the environment where we live, that they matter a lot for all these other things that we're talking about. Before each one of us make it to the doctor's room, we are living in different places, and those environments have an important influence on our health outcomes. So I hope that it becomes interesting to those of you who stay here to listen to this talk. Primarily, I'm going to focus a few things broadly. I'm not going to narrow down on the actual preeclampsia topic, but also related to mostly focusing on broader issues about hypertension and other outcomes related to the environment. So to start with, I think some of you who have been in the environmental health section would have noticed that of all the deaths that occur each year, I think since global health burden of disease has been tracking this, high blood pressure has been among the leading causes of death. Even the last two estimates, including 2019, put it the same way that I think 2019, there were about almost nearly 55 million deaths globally. And of those, 11 million were due to high blood pressure. And this can result in other outcomes such as cardiovascular disease and so on and so forth. I won't go much into detail. But what that means is that this is the same case, not just for one sex, but it's for both men and women. And that's been the case globally. So you can imagine a scenario where we are talking about hypertension in pregnancy, where if women broadly generally have elevation of blood pressure due to air pollution, that means that it's already going to push a lot more during that period, that sensitive period of pregnancy, into high level of hypertension that could lead to other outcomes like low birth weight, preterm birth, and so on and so forth. So, and then on the other hand, even though blood pressure is leading, we find that air pollution is equally an important contributor to the burden of disease and is the fourth leading risk factor, and that accounts for over 6 million deaths yearly. So, and when we're talking about air pollution, I'm making it broad to look at both outdoor and household air pollution combined together. And as you see from the pictures here, this will be an example. When I'm talking about household air pollution, I'm looking at what cooking in the household environment or the outdoor broadly sources that contribute to environmental air pollution will be something like traffic. But in a case of most of the developing country settings, places like Ghana, and most of you who have been there or who live there will realize that you can actually, disentangle the difference between the indoor environment and then the outdoor environment. Because if you live in a place like Accra, Many households are cooking with biomass fuel, wood and charcoal that is contributing a lot to outdoor air pollution. At the same time, not just for household cooking, we rely on this for street cooking for sale, baking, bakery, fish smoking, and so forth and so forth. And then traffic is another situation in Ghana that we all know about, something like that. So you can really disassociate the two of them and say, okay, this is due to household. So when I'm talking about pollution, I'm probably looking at the broad combination of all of these things, including other sources that I will touch on later on. So both the outdoor and household level air pollution have also been linked to elevated blood pressure. I'll give you just one quick example of some of the work from my own lab. There's a lot of data out there. I just pick a few that I'm just from my own personal experience and share with you to just throw light on that. It doesn't mean this is the exhaustive literature, no, just to show this as part of today's presentation. So we pulled together a data set from a very multi-country, multi-center study. We're talking about 21 countries in all of the across all of the income levels, from high income, upper and middle to low income countries. And then we try to answer these questions, whether long-term exposure to outdoor air pollution, outdoor and household air pollution has anything to do with high blood pressure. Because there has been so much evidence, if you look at it from whether cigarette smoking, which is one of the highest levels you can imagine, the extreme level of being exposed to air pollution, to some other industrial settings and things like that. But just normal outdoor, living environment conditions of air pollution, whether those relate to air pollution. And in fact, when we pull, these are the countries that I show up here in the dots where they are all located. So basically, including Canada, some in Europe, like Sweden, all of those, and across all of the continents. So, and you pull all of the data together, the evidence is supported that, in fact, long-term exposure to air pollution actually increases someone's chance of developing hypertension. And this is not specific to any gender. We see the same thing for male and the same thing for female as well. And you can see the distribution of air pollution level that we have assessed across all this country. If you see the levels are much lower, they are meeting mostly the standard for the WHO, which is around 10 microgram per meter cube year. If you look at particle concentration, then you move on. And the higher you go to the lower and middle income, lower and middle income, up lower and then the low income countries, you see that the levels begin to increase quickly. So keep that in mind. We will come back to that point later on. And then again, we did a work recently. We pulled a publicly available data, which is the DHS that is collected in various countries. DHS began to include blood pressure measurement. And we asked a very simple question. If you compare, what happens if you compare mothers, women who cook using what we consider unclean cooking fuel or dirty fuel, which I mean coal, animal dung, wood, charcoal, and so forth. And you compare those to women in homes that cook primarily with what we consider cleaner fuels. In this case, I'm looking at electricity and gas. And you ask this simple question. When you look at the average blood pressure in those women, compare, do they differ? And we pulled this data across all of these 10 countries right here, indicated here, including Ghana and Benin in Africa. And the overall conclusion from that analysis showed that, yeah, if you just compare on average, women in households that cook with dirty fuel, their chance of developing hypertension is about 16% more compared to women who use cleaner fuel. And the same thing is seen for even simple things like the parameter for blood pressure, which is something like systolic blood pressure. So it's becoming an important to realize that where we live actually matters a lot beyond just the clinical outcome that we develop. Where we live, everything begins in that environment. So I want to narrow down a little bit more on Ghana, specifically because this program is being focused on Ghana. And I'll give you a few examples how some of this can result in an outcome that mostly, if you go to your doctor, that may not be the first point of discussion that will come up. So we look at, if you take the national census, we took the last 2 recent national census. 2020 is not fully out yet, so we don't have access to those. But if you compare 10 years back, the 2 decades, 2000 and 2010, and we look at some of the conditions that describe the living environment in relation to the environmental conditions. Here, I'm showing you the distribution of all of these environmental factors across, or social factors also, across the districts in Ghana. So each of these bars represent one of the districts in Ghana, and we limit this to the old 170 districts. And then when you look at how fuel use, household cooking fuel use is distributed across those, you could see clearly that overall, even between 2000 and 2010, you will see clearly the majority of homes, irrespective of which districts, most homes, over 80% of homes, still rely on a form of biomass, which is in the form of wood or charcoal in a lower level here. And then you see improvement in cleaner fuel like LPG, liquefied petroleum gas, improving slowly over time. But in the best country, it only comes to about roughly 40% in a place like maybe a city like Accra. And then you look at other conditions like sanitations, also improving very drastically, drinking water sources doing well. And another factor that people don't consider, the social factor, maternal education is a key predictor of some of these maternal and child health outcomes. And we see clearly that unfortunately for Ghana, over those 10 years between 2000 and 2010, primary education increased, but nothing is happening with secondary or higher education among women. So that is a warning sign that probably improving some of these factors could result in better outcome for both child and maternal health. So we took one outcome, which is important for child health. You know, if mother has issues related to the pregnancy, one of the outcome could be that that child will be born low birth weight. The child born low birth weight means that it's likely to die. So we look at an indicator for this, which is child mortality, under 5 mortality among districts in Ghana. And what we have discovered over the same time period, 2000 and 2010, is that even though economic improvements are happening in Ghana, we see that really it's also reflecting in child survival broadly. And you could see that in 2000, the levels were quite, let me say, varied. If you look at the northern districts or compared to the southern district and some of those along the coast, like Cape Coast area, you see that the level vary from as low as maybe 60 deaths per 1,000 live births to as much as over 150. And then you move to 2010, you see that there is a major reduction in those. So there has been improvement. There has been improvement overall, but the question is whether those improvements, are they affecting all districts equally? So the next slide here, we look at it that on average, we show when you compare the two seasons, you will see that there has been reduction in child mortality in every single district. But unfortunately, those reductions were not equally distributed. You know, so some districts, like the southern part that started off very better off, were not doing that great when it comes to the 2010 period. So they were lagging even more behind. So inequality was increasing even further as time goes on. So the question is, why am I talking about all of these things and looking at air pollution? Before I move on, I say one thing, that when we compare the same estimated environmental factor, we found out that in Ghana, on average, we can reduce child mortality by about 11% if we increase the household that begin to use, on average, 10% of households, you switch them from using dirty fuel to cleaner fuel, and the 5 mortality will reduce by at least 11%. So that's an important information. But when you go back down and you look at broadly, globally, where are the highest level of air pollution versus where the levels are being monitored, you see clearly that from this graph, most of the countries that have issues with air pollution are within Sub-Saharan Africa and part of Asia. And if you look at the map below here, actually showing you where there is regulatory monitoring going on by government or the city authorities to make sure that air pollution is regulated, you see clearly that nothing is really going on that much in Africa. So that led me to my case where we begin to figure out how do we support some of these countries, knowing that air pollution and other environmental conditions can have implication for both maternal health and child health overall. So some of the things we already know, so I won't spend so much time on them, that there are all of these situations happening in Sub-Saharan Africa, if you're looking at it from the perspective of air pollution, that there are so many sources, irrespective of whether you are in the city or you are in a rural area, combination of both traffic, combination of that alongside with biomass use is an important factor. And then we have a big issue in Ghana also across other West African countries as well, which is the harmattan. During that time, the levels increased extremely high. So just take a look at quickly what we are doing so far is that this is a picture of Accra, giving you a good sense of the environment. As some of you who live there already know, Jamestown, Choko area is looking here. La Paz motorway is here, a lot of traffic. This is Makula area. So you can see, and then there's a lot of preaching, there's a lot of sounds going on. So there is this combination of road traffic air pollution as well as traffic noise and then general environmental noise that is happening. The question will be, how do these things affect maternal health overall and then child health overall? There is a lot of questions to be answered when it comes to the West African or Sub-Saharan African region. So I'll move on with a few slides, just telling you some of the work we are doing in that sector. First of all, to contribute to the availability of data and be able to sensitize the nation about what air pollution levels there are and what we can do to improve those. So we set out to monitor levels of air pollution and noise pollution in the Greater Accra metropolitan area. And we have set up over the last 2 to 3 years, sites in about 150 sites across the city. And as you can see, these are the sites that we have monitored. So in the next few slides, I will just go through the set of results that we find. And you may have, if those of you may be working in Accra, you may have come across some of these setups somewhere randomly. That may be our monitors that are out there. And we are monitoring a lot of things, from particulate matter to nitrogen oxide to sound level to other sources. But I'll focus on a few just for the purpose of this discussion today. So just focus on particles in the air, just in Accra. As you walk in Accra, out of all of those 150 sites that we have measured, what I want you to pay attention to is that we regroup each of those sites into community level ideas. So are they background sites, like here in the blue? Are they from middle or low density communities, residential communities? Or are they high density communities, which are mostly poor neighborhoods unplanned, or they are just industrial? And what you see clearly here is that there is this clustering as you arrange the levels to the highest level. You see that mostly high residential, which is mostly low SES communities, and residential, what do you call it, commercial and industrial areas, they have the highest level compared to general background sites or medium and low income neighborhoods. And then to put things in perspective, you want to look at this line here. Currently, this is a WHO approved standard, which is the 10 microgram per meter cube in every air that you take. But in Ghana, even our best sites, which are all of them background sites, if you can imagine background, talking about a place like maybe you are in Legon, where there is a lot of green space, there's a lot of not much cooking or traffic going on in some of those places. Those are our best places. However, even our best places have not met the WHO standard, annual standard, let alone the 24-hour average. And then you can see the distribution across all of these sites that we have measured. So that's an interesting point. So there is a lot of spatial variability in air pollution in Ghana, and the levels are a little bit concerning that we need to be worried about. If you also look carefully at also seasonality, we see dramatic increase during Harmattan. As you can see from here, the Harmattan setting, then levels begin to increase 3 to 4 or sometimes 5 times higher. And that's the case in any site. No matter how you look at the data, the Harmattan is very, very important contributor to air pollution during that time. But we would have expected that maybe just the air blowing, the dust coming in is the one increasing the air pollution. But when we look at the distribution of nitrogen dioxide, which is an indicator of combustion sources, something like traffic, you find out clearly that even traffic also increased during the Harmattan. Sorry, nitrogen dioxide increased in the Harmattan. The question is that also coming with the dust? And we find out that's not the case. So it's likely the changing in the environmental condition around that time is also increasing the existing levels. So even though we are emitting the same amount, the levels are kept and they are not being diluted quickly, so the levels increase higher during the Harmattan. So that's an important finding for policy. How do we deal with this kind of situation during that period? And above all, I want to say that it's not all gloomy. Compared to 10 years ago when we did a measurement, we have seen so far about 50% reduction in some of the high pollution neighborhoods so far. So that's a good news. That's a great news that levels are decreasing overall. However, it's only the particles that are decreasing. Nitrogen dioxide, on the other hand, which is traffic situation, is worsening. And I'm sure all of you who live in Accra will bear witness that traffic congestion kept increasing and increasing. That is actually being picked up by our monitors that nitrogen dioxide levels are increasing. And all of these have major implications for both maternal and child health outcomes. And then if you look at noise, again, the same similar sources could contribute to noise. And our noise level are no different from what I have just talked about when it comes to air pollution. So what is the point? The point is that as we make every effort to improve maternal and child health in Ghana, and for this conference, particularly focusing on maternal health issues, we have to be also beyond the treatment, beyond the other clinical interventions. We have to be mindful of the environment where the mothers live, because by the time what happened pre-conception in the mother's environment has a major implication for the mother's health itself, and also the outcome of that pregnancy as well. So what we are planning to do next steps will be to work with folks on this platform, including Joyce and their team. We are planning to create, use the data that we have measured to create pollution surface, like this example that we have just completed recently for nitrogen dioxide, so that we will be able to predict levels at any part of the city, so that we can actually demonstrate the relationship between these exposures in the environment and then some of these outcomes that is of interest to this group. So overall, that is our goal, that we will contribute to data, and that data could be used in epidemiological studies and also inform policy with the Ghana EPA, that are there ways that we can actually support clinical outcomes, actually targeting environmental conditions overall. So I think this is the message I want to share with some of you here who are medical practitioners and things, that there is this other side that has to be brought into the equation if you want to approach these maternal health issues like in an integrated way or multi-sectorial way. That may be the best way to go, to also include environmental conditions in addition to clinical interventions as well. So what is the key point? There is a lot of air pollution levels and noise in Accra that are at levels that are health concerning, that we have to worry about. And then we believe there are some socioeconomic gradient as well. Levels exceed international and local guidelines that we would have hoped for. Even though there are improvements, there is a switch going on. There is a shift from biomass use. Now we think that traffic is becoming the dominant source of air pollution in Ghana. So all of this may require multi-sectoral approach, whether it's in the built environment, the road design, the policies that control noise or churches, all of those things. there's got to be a conversation, there's got to be a discussion broadly to see how best we can improve the environment where people live, to make it cleaner and then make it quieter to improve health overall. Thank you. These are the collaborators, so I'll pause here for any questions or discussions as time permits.
Thank you. Thank you very, very much, Dr. Arku, for such insightful discussion on the contribution of air pollution to preeclampsia and indeed maternal and child health. In fact, it's interesting to note that long-term exposure to air pollution could increase the risk of preeclampsia. I must say this is really new to me, and that we could indeed decrease by 5% child mortality if we are able to switch from dirty fuel to cleaner fuel. This is really, really insightful. Thank you so very much for sharing this with us. Now I would like to take questions. If you have questions for Dr. Arku, kindly indicate by raising your hand, or you can also type in the chat box. Claire has a question. Kindly unmute yourself and ask your question, Claire. Thank you.
So not a question, just so much as a sidebar that people might find interesting. A study that my colleagues and I did in a cohort in Memphis found that African-American women who had exposures to air pollution, mostly produced by traffic, and their children, if they had a particular gene variant, had a higher risk of elevated blood pressure. And that effect was seen more strongly in the female children versus the male. So I thought that was a nice addition to what you were talking about.
Thank you very much, Claire. That's an interesting research finding that lends credence to what Dr. Arku has just shared with us. But it is interesting to hear that it's more prevalent in the male child than the female child. Any reasons did your study find out? Claire, you want to share with us? Or Dr. Arku, any additions to what Claire has just?
It just will not allow me to unmute myself. It's extremely strange. Yes, it's the female children who are most affected. We don't have a good explanation for that. You know, I can't tell you why that is. I think it's both interesting and concerning.
I can add a little bit, not directly to answer the question, but and this may not apply to a place like the US. If you take our context, Ghana, for example, we have done what we call personal exposure measurements. And even among school children, it's interesting to know that exposure varied by gender on its own. And in Ghana, we have demonstrated that girl child going to primary education, elementary level, on average, they have close to about 5 to 10 microgram per meter cube increase in PM compared to their male counterparts. And in our context, it might be because of the role of the woman. So the girl child probably is by the mother working a lot, exposed to some of these household cooking, as well as they do some of the chores in the house, and then they are more exposed than the boy child. So I'm not saying this explains yours, but there is also gender differences in the exposure, which could likely result in the differences in the outcome as well. So just to chime in based on the data we have from children in Ghana.
Interesting.
I think my question that I want to throw out to those of you who are in the medical sector is, in terms of policy, is there a role for, especially our doctors, is there a role for thinking about the environment as an important contributor to all of this? I know in many cases it's been focused on clinical intervention. Do we think that a place like Ghana, because I know most people in Ghana know, they believe that noise is a problem. They also believe that air quality is a problem and traffic congestions are issues. So the question will be, do doctors on this platform think that there is a role for the environment, and how can that be included in policy issues, or even discussing this with their patients when they come to the office to talk about some of these health outcomes.
Dr. Shroff, you can respond to the question, please. Please respond to the questions being engaged in.
Thank you so much. Thank you so much. So the question is, do we doctors in Ghana think that there is a role for the environment, and then how will this relate to policy? So this is what I understand. I think that this whole knowledge of the environment, pollution, noise, has an impact on preeclampsia risk. For us, it's coming as something relatively new. It is a discussion that has started only recently. Normally, before something will get to the policy level, it has to go through the full rank of clinicians, recommendations, advocacy, and then it now comes to the policy level. But this is a very important knowledge that is coming through. Because now when I have my patients, if pregnant women come to book with me, if I have data to show where they stay, and I have an idea that the impact of where they stay on their health status, I'll begin to counsel the woman from that point of view. In addition, if I have data on the kind of fuel, or if the woman comes to me pregnant in the early stages, then these are things that I can easily explore. What kind of fuel domestic fuel do you use, and so on and so forth, so that I can begin to advise her and counsel her on the changes that she could bring about in order to reduce the risk of developing some of these complications that you are talking about. So this is the right place to start from, and that is from the advocacy point of view, and then also from the education point of view. We need to share this knowledge widely for colleagues, obstetricians. For example, during the Obs and Gynae conferences, this knowledge must be brought across so that we can begin to counsel patients and talk to our patients for them to understand that these are the changes that they can make to their own life in order to enhance the quality of their own life before it gets to policies level later on in our development. Thank you so much.
Thank you, Dr. Raphael. There's a question here in the chat box. I'm not very sure who is well pleased to answer this. Audrey wants to know, who is to ensure that environmental laws are obeyed, especially here in Ghana?
Here is, how can we prevent further air and noise pollution while still growing our cities? In other words, what's the solution? What's the proposed recommendation, on how to curb this pollution? I mean, obviously, we are in the cities. We don't want to migrate, or and more women, more children will go to become women. More women want to have children, and so, what would be the recommendation as a way forward?
Okay. Yeah, I'll give it a shot. Thank you for both questions. So there are two set of questions here. One is asking, first of all, who is responsible for making sure the environment is clean, or of implementing laws that will improve the quality of the environment. And then the second one is asking, in terms of development, what's the way forward? Because I think we want to develop at the same time, we want to have a clean hands, and they look like they go opposite each other a little bit. So I'll start with the first part. So every country has mandated certain agency to be responsible for keeping the environment clean. In terms of Ghana, it is the Ghana EPA, which is the Environmental Protection Agency. Colleagues from there, including the director, Mr. Raphael Arku, and their team, we have been working very, very closely with them, providing technical support and also capacity building and providing data that can help them. I'm a Ghanaian myself, I grew up there. So the issue, as I see it, is, as I use the word, multi-sectorial. The EPA, so far, I don't think they have a mandate to actually implement any or enforce any rules to control pollution in any form. I think they are producing data. Data could be shared with some other agencies, like maybe if it's the AMA and others that may have the capacity to do that, they will do that. But here's the thing, EPA cannot work alone in isolation of other agencies. If you take, for example, if EPA is trying to implement laws by the licensing authority and licenses every used imported vehicle that is polluting a lot or almost dead, 10-year-old and above, are coming from Europe and the USA. The problem is that Ghana EPA can do little about that because those lie in the hands of the Ministry of Transportation and then maybe the licenses office. On the other hand, if you think about the town planning, right? City design, how do we design our cities in a way that it helps to improve air pollution, right? Now everything is basically all over. There are no zoning, there are no planning here and there. The churches are somewhere right behind somebody's bedroom. You know, roads are not well paved. Those that are paved are not usually swept. So there's risk suspension of dust. If you decide that, okay, I can cook with electricity, unfortunately, there'll be times where the light will go off, right? If you want to buy LPG, not always available. So you see that there's got to be this systematic approach involving multi-sectors that will come together and say, this is important. We can leave it to just one agency. There's got to be multi-sector approach. That's been my message all along so far. And then on the other hand, yeah, can we develop? Yes. Can we develop and keep a clean environment?
The meeting, hello. The meeting.
Can we develop and keep a clean environment? I think there are models we can follow, but it all starts with data, right? Do we have a data set to show that, like, for example, we begin to show this data, then that means that we can do things quite differently. Development is good. Economic improvement is good. They have some benefit. People are moving from place to place easily. Access to hospital, you can get onto Uber right now and go easily. However, there is this secondary or added adverse outcome due to this development. The question is, do we see environmental conditions as an important factor as we plan our developmental outcomes? If we think that is an important, then they will come into the equation so that we can design a developmental path that will include environmental impact assessment that will actually be implemented in a way. For example, when the new roads are built, what are the plans do we follow? When new schools are being built, new hospitals, some of the hospitals, their location alone, the environment where they are, the air pollution in those places, there are short-term impact could result in somebody having maybe a short-term outcome, even just visiting a hospital because the environment is polluted. So I think Doctor said it earlier, it's got to be begin to talk with the discussion, civil education. People begin to make this an important topic, beyond just the politics and also beyond other things that we focus on, like maybe malaria, fuel prices. We need to talk about this as well as a day-to-day issue because air pollution and noise affect a lot of things, even fertility. Even fertility. There is evidence that people are having difficulty having babies just because they have been exposed to air pollution. So that is an important discussion that we need to begin to have as a nation, and then that will be factored into every aspect of our planning and development.
Thank you very much, Dr. Arku. Indeed, this requires a multi-sectorial approach to solving the problem of environmental pollution. Probably take our last question, and then we'll allow the other groups to join the main group. And Aubrey's question says, how are we bringing this information about the negative effects of air pollution to the masses? So we are learning about the negative effects of air pollution today. How are we bringing this information to the doorstep of the layman? Dr. Arku, can you help us with that? Thank you.
Yes, thank you so much for that question, an important one. So what we have done so far based on our work is, first of all, to have, we held recently policy stakeholders meeting in Ghana where we shared some of this information with major people from the Ministry of Health, EPA, the Ministry of Environment, the city authorities. we are sharing the information with them and engaging them in this process. That is the first step. We have recently just published a paper on the noise pollution, and we are currently in touch with the Daily Graphic and possibly one FM station, I think it's CDFM, try to see whether they can carry the story and share it with slowly become part of the discussion. I'm hoping for a time where we will begin to engage religious leaders, whether the pastors, the imams, into some of this conversation that they can talk about this freely in the churches, because this is affecting everybody, whether you believe you are a Muslim or you are a Christian or a traditional practitioner, a traditional believer. All of this affect us. So those are the powerful people, stakeholders that we are slowly targeting. Can we bring them into this discussion? And then they can carry the message to all the others and see whether there will be awareness creation. And if there is awareness, probably we will begin to hold our members of parliament responsible to make laws and implement laws that will actually help improve the quality of our living environment.
Thank you. Are there any plans to engage the media as well?
Yes, we are, as I said, we are about to engage Daily Graphic for a story on noise pollution. We are also trying to engage City FM on some of the outcomes. So as they come, slowly we want to begin to talk about with media, maybe the morning shows, for example. We hope that we can have a chance to share some of this in the early morning show for a lot of people, maybe Peace FM, Joy FM, City FM, and then GBC, to begin to draw attention to it. So there are steps slowly as the data begin to come out and are published in peer-reviewed journals.
Fantastic. Thank you very much, Dr. Arku. I'm very certain that as we begin to take these steps, we will be heading towards indeed reducing maternal and child mortality. We'll still be engaging you. You can send your questions in the chat room. At this point, we want to allow everybody in the breakout sections to join us. All right, okay. Thank you, Dr. Arku, very much for the educative section. We want to continue with the conference. We are almost drawing our curtains on it. So Gina, take over.
We have one final question for you, and that is, what is the most important thing you learned today? And we would love it if you could type this in the chat and we can have a look.
We've had a very diverse program today. And we also would like to use this input to for inspiration for future sessions. Action on Preeclampsia Ghana, together with the Spot Studies, organizes regular webinars. And what resonates with you, the topics you find most interesting, lessons you learn, things you would like to learn more in the future, we can all take with us in the planning of future events.
We have one comment in the chat already saying the mechanism of action of magnesium sulfate as the wonder drug for managing preeclampsia. That's great to hear. I just learned in the session with Raphael Arku that there's a very significant relationship between air pollution and noise pollution and fertility. And he told us that people are having trouble having children now sometimes, and that can be related to air pollution as well.
And I see a number of quality of care issues mentioned too, that prompt referral is important to minimize maternal morbidity and mortality, that a multifactorial approach to the management of clients is essential in order to achieve quality healthcare with desired outcomes. And we need all the different professions for this. And in fact, Isabella proposes it's actually a hallmark of the quality of care, our ability to work together as a team. Anita Frimpoma Opong mentions that she has learned that calcium supplementation and soluble aspirin can be used as a prophylaxis for high-risk patients. The role of midwives and empowering midwives is emphasized in the chat. And overall, that we need to continue to work on better treatment. APEC Ghana is a volunteer-run organization with a national activity in every region, or nearly every region they're active, and volunteers are always much welcomed to support the cause and activities. Isabella or Linda, could I invite you to take it up from here and finish it further?
Thank you very much, Joyce.
Thank you.
Judging from the comments from the section, the chat section, it's evident that this conference has been very educative. Everybody has one message that he or she is taking home. And so I'm confident in saying that this discussion, this conference has been very insightful. It's been very educative, and we are all gearing towards reducing maternal and child health mortality as a result of preeclampsia. And so on that note, we want to say a very big thank you to our chairperson, Dr. Mary Coleman. We are really grateful to you for sharing and spending time with us and gracing our occasion to make it a very beautiful, successful program. To our special guests, our distinguished speakers, you not only graced our occasion with your presence, you've shared your rich knowledge with us, and for that we are truly deeply grateful to you. To our partners, our sponsors, the media team, the planning and the organizing team, and of course to you, our participants, we are indeed very grateful. We couldn't have had a successful conference without you. We are delightful that you could make time to join us. We are certain that everyone is leaving this meeting with new ideas to improve maternal and infant health. We look forward to having you join us again. And until then, we ask that you have a very pleasant and restful weekend. We urge you to keep sharing the knowledge that you have learned about preeclampsia so that we can all save a life today. And on that note, I say thank you once again to everybody, and bye-bye from all of us, the APEC team, as well as the sport team. Thank you, thank you, thank you very much.